Thank you. Again, thanks to the organizers for inviting me to speak. So we're going to talk about treatment of lower risk MDS. And as you just heard from Ray, we're talking about IPSS low and intermediate ones. These are basically patients who have less than 10% blasts and who do not have complex cytogenetics, not -7. I chose to use this instead of the newer IPSS, as all the studies that we're talking about to date have reported based on the old IPSS. So this is a old schema from Atala from 2008 on how to treat MDS for both lower risk and higher risk. And today we're going to focus on the lower risk group and go through each of these different treatment modalities. Let's start with transfusion and growth factors. Virtually everybody with MDS has low hemoglobin at diagnosis or will need transfusion at some point in time. It's been shown that morbidity and mortality are higher and the quality of life lower when you're anemic. RBC transfusions are the standard of care. When to transfuse has classically been for patients who have a hemoglobin less than 8. That's probably insufficient. The current recommendations from some groups are to keep males above 9 and females above 8. The downside could potentially be iron overload, alloimmunization, and infection risk. So Dayani and colleagues did a trial to see whether or not patients with MDS were dying from organ failure, possibly due to iron. And among their causes of death, they did not record any of them as being due to iron overload. Although high iron has been shown to increase the susceptibility to infections, and so there may be a contribution there. Nevertheless, it's been shown in a couple different studies that if you have an increased ferritin, that this is associated with a poor prognosis. And the top is a figure from a paper by Garcia-Minero. If your ferritin is over 1,000, you do less well. And in the bottom, a study by Malcavadi showed that as your ferritin increases continuously, your risk of mortality increases continuously. So there are a lot of modalities that are available to us to chelate iron, and it's actually been shown that iron chelation improves overall survival in several retrospective studies as listed here. One study also shows that it may delay transformation to AML, and it may lead to some hematologic improvement just by removing the iron. So the standard of care is probably to keep the ferritin less than 1,000. This is based on 4 consensus papers that are listed. And you should consider this for patients who are requiring more than 2 units a month, have a high ferritin over 1,000, especially for the RARS and 5Q minus patients, and if they're an allostem cell candidate, as high iron at the time of transplant has been shown to be bad. What agent you have available to you is going to vary on what country you're in, so you'll have to use what's available. Erythropoietin in either the short-acting form or the long-acting form is indicated in all international standards for the therapy of MDS. It's more likely to work for those with RA with ring sideroblasts that are less than 15%. Those who have normal cytogenetics, this predates the molecular analysis. Those who do not have a response in endogenous EPO levels and who are getting less than 2 transfusions a month. There's no data to support increased transformation to AML with EPO in MDS. It may improve survival when it's combined with growth factors. And as a clinical pearl, if you see loss of response, our immediate idea is to think that the patient is progressing. But you should look and make sure that they haven't become iron deficient, because a lot of these patients will become iron deficient as they start making red cells again. And if you replace the iron, they will now have a recovery of their response. In this study, the survival benefit from EPO was restricted to those who were getting 1 unit or less per month. There was no survival benefit in those getting 2 or more units per month. But regardless of how many transfusions you were getting, there was no increase in your progression to AML. Likewise, platelets are required in the majority of patients at some point in time. Transfusion, the raw number, has only limited correlation with the occurrence of bleeding episodes. We all use them prophylactically, but there's little evidence that it benefits. And the problem with this is that many develop alloimmunization. There are currently 2 growth factor, platelet growth factor mimetics, romoplastin, which acts at the MPL receptor, and eltrombopag, which sort of acts like a synthetic thrombopoietin, that are available. This study done by Kantarjian looked at romoplastin in a dose-escalating study. They found responses in 18 out of 44 patients to over 100,000 platelets. They also saw a transient increase in the blasts in these patients that resolved. And many of these patients could keep their platelets high. The question is whether you would continue using this rather expensive therapy ad infinitum in a patient, and to what end? What endpoint should you use? A little bit of kerning problem with the transformation from one computer to the other, but we're going to talk about immunomodulatory agents. I won't talk about CARs, those are in the future, but let's talk about ATG cyclosporin, the IMiDs, and alemtuzumab. So based on the, thing shifted a little bit, sorry. Based on the results in aplastic anemia, people have looked at ATG or ATG plus cyclosporin in MDS. And in general, a fair percentage of patients, somewhere between 20 and 40, will develop transfusion independence. Some patients will get a CR. Some papers have suggested that there may be some improvement in overall survival over time. There is only one randomized study, this one, number 4, where they combined ATG and cyclosporin versus best support. And while the response rate was vastly different, the median survival did not improve at all, and in fact was non-significantly worse in those who got treated that way. Here's another summation from Dr. Lim's colleagues. You can see that hemoglobin and platelets go up in about a third, but neutrophil responses are less common with ATG cyclosporin. Patients with HLA-DR15 positivity do better. You do not see cytogenetic responses. Some patients with deletion 5q will respond, and predictors of response for bone marrow hypocellular being low and a low IPSS score. Shifting to lenalidomide, this has been used and is approved for use in patients who have deletion 5q minus syndrome. The majority of these will become transfusion independent. 67 will get a complete response. These responses occur pretty quickly, usually within the first month. Response is maintained for at least 1 year in about 5/8 of patients, but most will over time lose their response. Cytogenetic response is less common. If you have platelets less than 100,000 or you've been requiring 4 or more units, you are less likely to respond. 8% of these patients died largely from thrombotic episodes, so some sort of anticoagulation is standard of care for these. The majority require some sort of dose reduction for cytopenias. This study from Fano compared placebo to 5 or 10 milligrams of lenalidomide, and the transfusion independence rates were a little bit higher with the higher dose, as was the increase in the hemoglobin. Cytogenetic responses were also better, and there was no increase in progression to AML compared to the placebo with these patients. Lenalidomide has also been looked at in non-5q minus MDS. Large study from RASA, 214 patients using the same 10 milligram 3 weeks out of 4 dose. Overall response rate was 43%, but this includes predominantly patients who achieved transfusion independence. Again, pretty quick response within about a month. Most of these last about 2/3 of a year. Another 50% had a reduction in the number of transfusions that they needed. Again, penias were the main toxicity. They did not provide us with information on leukemic transformation in this study. Because thrombocytopenia was a problem, somebody looked at, Dr. Lyons looked at combining lenalidomide with romiplastin, but there was no benefit from doing this. CAMPATH has been looked at for similar reasons. It seems to work in some aplastic anemias. Maybe it'll work here. In this study from Sloan, they screened a large number of patients, only a quarter of whom met a complicated mathematical formula based on their HLA-DR15 expression, their age, and the months they'd been transfusion dependent. And within these 31 patients, 19 of them are low-risk MDS. They did see a pretty high response rate. Again, this is mostly in terms of transfusion independence, although the CR rate progressively climbed over time in those who were able to stay on study for longer periods of time. This was true in the intermediate 1, even some in the intermediate 2s. Most of these patients got transfusion independence, as I said. Toxicity, again, was mostly cytopenias, a lot of infections, and in this study, nobody progressed to AML. Hypomethylating agents are probably the most commonly used drug, and my little comment in pink is to remind you that even though they're supposedly hypomethylating agents, there's a wealth of evidence that suggests that that ain't how they work. Rather than go through the plethora of studies, I thought I would give you some general truisms on their use. One, they are not curative. DAC is approximately equal to AZA in terms of its response rates in the studies that it has been looked at. There has never been a head-to-head study of DAC versus AZA published to date. A third of patients will show hematologic improvement. Half of those that are transfusion dependent will become independent. Complete remissions are uncommon, occurring in less than a sixth of the patients. Be patient. It takes many cycles to get there. If you interrupt therapy, you're going to lose your hematologic improvement, or the patient may relapse, so try to avoid that. Comorbidities are much more prognostic than age. Cytogenetics, those who have monosomies, are much less likely to respond. If you are put on a hypomethylating agent, your survival overall will be better than if you were treated with standard of care, no care, or low-dose ARC, as this paper from Fano that Dr. Jabbour showed earlier showed. Only AZA has been shown to be beneficial for intermediate 2 cytogenetic patients to date. If you relapse while you're on one of these therapies, your outcome is very poor. It doesn't matter if you're on DAC, as shown by Dr. Jabbour, or azacitidine, your survival is less than half a year. If we add something to hypomethylating agents, can we improve the response? So here are 3 studies looking at a histone deacetylase inhibitor, 3 different ones. And in general, the response rate is not significantly higher, and the survival is maybe a smidge better. TNF-alpha inhibitor was added. This trial had 15 low-risk MDS patients. The median remission duration was a little bit longer than has been seen with the just hypomethylating agents by themselves, but a lot of these patients progressed. I'm sorry, the wrong study there. So that might be interesting. Gemtuzumab plus Hydrea, very few patients, a couple CRs, relatively long remission durations, might be interesting. Lenalidomide in combination, there are only 5 intermediate 1s treated, but 4 of these went on to get a CR. In this study, 8 patients went on to get AML, but since the majority of them were more advanced, that may not be due to the lenalidomide. Some different dosing schedules and routes have been tried. In this trial, they looked at azacitidine, different doses and different durations of therapy. But if you look at the response in the red cells, platelets, or neutrophils, it doesn't seem to have been affected by which regimen you got. Dr. Garcia-Minero and others have been looking at oral azacitidine, and the take-home message from this is that at proper doses, the overall response rate seems to be pretty similar to the sub-Q. You can achieve levels, the blue line, that are similar to sub-Q azacitidine, the yellow line here. And in this particular trial, they gave patients sub-Q AZA on the first cycle and oral AZA on the second cycle, and the hypomethylation seen at day 15 in each of these cycles was statistically significant. Statistically similar. It's also been looked at using DAC in a schedule of 3 days every 28 days versus weekly. While the weekly schedule gave similar transfusion independence rates, you saw fewer responses in those patients. And they also had somewhat inferior survival, although not statistically significant. So the weekly is probably not as good. Stem cell transplantation, currently only about 5% of patients make it there. The problem with transplant for these patients is not relapse, with only 10%, 12% dying from relapse. It's the non-relapse mortality, and that's been the big cause of death in these patients. And given that intermediate low have a median survival of 11 years and intermediate 1s 5.2 years, these survival curves are not that impressive for patients who are under 60. And I'll point out that the median age in this large trial was 39 years. This is a very young group of MDS patients. So perhaps not that impressive, but perhaps we would see a late crossover if we got a follow-up. The CIB-MTR did a Monte Carlo style analysis looking at cohorts that got where they followed the natural history or got hypomethylating agents or got reduced intensity conditioning transplants. And in this, regardless of which of those you use, RIC did significantly worse than those patients who were not transplanted, and the CIB-MTR concluded that transplant was contraindicated for patients with low-risk MDS. As you just heard from Dr. Wong's study, we now have a whole lot of new genetic information. As he talked to you, if you have one of the bad mutations, you move from low risk to intermediate 1, or from intermediate 1 to an intermediate 2 survival curve. So perhaps we should advance therapy by one class, and if you have one of these mutations, you should be following what the next speaker says and not what I've said. We obviously need new agents to target these mutations. So in conclusion, the standard of care today, transfusions are standard of care. Jury is out on thrombopoietins. Iron chelation should probably be standard of care, although I will admit that we don't use it as standard of care at the Anderson, although we're starting to. Growth factors are beneficial for about a quarter, especially those who have low EPO and are getting less than 2 transfusions a month. Immunomodulatory agents, helpful in about a third of patients. Again, pick those that have low bone marrow cellularity to try. Hypomethylating agents seem to show benefits across the classes. Lenalidomide, good for 5q- and helps about 30% of non-5q-. Alemtuzumab may be beneficial for those with advanced disease. Combination therapies are under investigation. We, of course, encourage everybody to go onto a clinical trial. Transplant could be curative. The benefit is debatable. And for the future, we should look towards the CARs again and towards new agents that are specific to the mutations. And I'll stop there.